All right, thank you so much for that lovely introduction. Elder Bailey and I are delighted to be here to share some of our work with you. These are our disclosures. We have NIH funding, and we have received funding from the American Heart Association. And Elder Bailey, take it away.
Well, good morning, everyone. We're so glad and delighted to be here with you. Our premise or work is at the intersection of community and the health system is needed to achieve healthy equity. We have worked together for the last 13 years. And what we have found is that the health system, which provides evidence-based practices, healthcare, health system needs, and community, which is community-built solutions, community cultural expertise, and built around community needs. And so our work then begins to intersect. Next slide, please. The continuum of community research. If you look at this slide, you'll see that from the traditional work to community research, and then on to community-based participatory research. Community-based research is research within the community or as in the place or in the setting. And it has sometimes limited community involvement in terms of the development and even in some of the decisions that's made within the research. Community engaged research or research within a community or with a community, community and the academic partners share expertise, share decision-making power and project responsibilities, and recognize the unique strengths that each bring to the table. We recognize that each of us will bring something to the table that the other may lack or may not have the skills to actually bring forward. Next slide, please. We've been partners in research since the fall of 2009. And as you can see, at the time I was the elder at the New Jerusalem Full Gospel Baptist Church. I'm still in Full Gospel as an elder, only I pastor my own ministry there now, Portraits and Christ Ministries. Leslie and I began this work with within the church structure, recognizing that many of our community members attend many churches within many different churches within the city of Flint, and it's been a joy. Next slide, please.
We look so young.
I know. I didn't have so much gray hair then. We've developed a community advisory board for this project, and it comes from numerous sectors of the community. The goal is to promote health equity through actionable research in the city of Flint and in the state of Michigan. And it is comprised of stakeholders from more than 30 organizations and individuals. And here you see a few of our partners.
Sorry.
That's okay. Next slide. Oh, this slide. Okay, community partners ecosystem. As you can see here, we have hospitals, churches, faith-based organizations, support groups, pharmacies, farmers market, beauty and barbershops, senior citizens, centers, soup kitchens and food centers, the Chamber of Commerce, neighborhood advocacy groups, community centers, the YMCA. Community partner ecosystem control is a lot of different groups, civic organizations, public libraries, schools and universities and colleges, extension programs, community academic partnerships, health coalitions, community organizations, movie theaters and radios and TVs, cultural organizations such as art councils and community leaders and area agency on aging. All of these different groups make up the community partner ecosystem. And without them, all that centers around the work that we do, we could not be successful in our work. Next slide, please.
Do you want me to take this one?
Yes, go ahead.
Thank you, Sarah. We, as you can tell, we are used to co-presenting, so we can swap on and off quite easily. So this is to give folks a sense of what our three main pillars are. So I think all of our work is centered on engagement. So very similar to the ROAR principles, we have community participatory research groups. So we have community advisory boards. We've also been more and more engaging with tech companies. We have a suite of tech studies that we are studying as a way to try to reach more and more people. But we also recognize that we also need to engage with sort of higher level decision makers in communities. So these are our health system partners and our state and local policymakers. We are primarily a research group, so we're not a practice group, but that we're not implementing evidence-based practice interventions. We're sort of trying to develop those interventions. And we do that through these 4 projects currently. So our main project that we've worked on is Stroke Ready, to promote acute stroke treatments in the city of Flint. We then moved to working on stroke prevention through these next 2 studies, which we call Reach Out and My BP, My Life. And finally, at the request of our community partners, we moved into some work optimizing aging with our McFarland and Hamilton partners. We firmly believe in capacity building within the community and within our trainees. Some ways that we are doing that is we have student interns now. Yesterday, Sarah and I hosted about 20 of our team members, including the majority of which were some of our summer fellows and summer interns to Flint, so that they can get a better understanding, not only of what your community looks like today, but what it looks like from a historical perspective, thanks to Sarah's deep and extensive knowledge of the community that she was able to share with us. It really had a profound impact on our team, and I'm really grateful for that. Again, we train Michigan students, Michigan residents, Michigan undergrads, and then we also participate in community engagement sessions, similar to things that we're doing today, and other activities where we're trying to build capacity of community partners. We decided that after giving a sense of an overview of what our research looks like, that we would try to also discuss share some of our program with you to increase awareness of acute stroke treatments. And so we have a next couple of slides are focused on stroke. So the take-home messages are that stroke is a medical emergency. There are clot-busting drugs that increase the chances that if you're having a stroke that you'll recover. The best way to get that is to call 911, and that most strokes are preventable. There are 2 kinds of strokes. One kind of stroke is a bleeding kind of stroke where a blood vessel breaks in your brain. The other kind is an ischemic stroke where there's a blockage. So blood is blocked. So if this is your brain, this is blood flowing through it. It's stopped. And this part of your brain isn't receiving any blood flow anymore. So that part of your brain will die. Stroke is really common. Most of you on this Zoom meeting probably know someone who's had a stroke. There's about 800,000 strokes every year in the United States. This is Michigan Football Stadium, holds about 100,000 people. 8 times that number will have a stroke each year. It's the 5th leading cause of death, and it's the leading cause of disability. I think that that's a really important fact, because stroke is a disease of the family, not just of the individual. The stroke survivor will often need a lot of support from their family and their social networks, which causes changes in family dynamics, caregiving, not only for children, but for the caregiver and if they're caring for their loved ones, older adults as well. African Americans have more strokes than any group in the US. So what are the signs of stroke? So the signs, strokes can cause different signs, and it depends on where that blockage is in your brain. And that's why it looks different in different places. So the easiest way to remember the signs of stroke is this acronym FAST that we talk about. And hopefully, since many of you live in Flint, you've seen our work and you may have seen some of this before. So F stands for face drooping. So you can see that this woman has a facial droop. R is for arm weakness. A is for arm weakness. S is for speech difficulty. So that's difficulty understanding or producing speech. And T is for time to call 911. You could check if you think someone's having a stroke, you can check to see if they're having any of these signs by some simple maneuvers. Face, you can ask them to smile. Arm, you ask them to raise up their arm. Speech, you ask them to repeat something. And then T is obviously to call 911. It's important to recognize stroke because there's a stroke treatment called TPA, which is the clot buster drug. So pretend that this is a pipe or a blood vessel. The water's flowing through your pipe here. Then there's all this blockage, and so the water can't get through. What we do is we give the TPA, which is signified by these yellow dots here. That chews up the clot, and then the water can flow through again. This was the same in your brain. So if this is blood, this is the clot, this is the area of the brain that's not getting any blood flow. We give that TPA, it chews up that clot, and then the blood flow can flow again. The blood can flow again. It's important to get the medicine as soon as possible because that increases the chance of recovery. The TPA works better the faster it is given. Basically, the faster the clot is broken up, the less brain that dies, and the greater the chance of recovery. In order to get that medicine, calling 911 is the best approach. That's for a couple of reasons. One, the paramedics know how to treat a stroke. Two, they can call ahead to the hospital to let them know you're coming. So oftentimes the stroke team is waiting for the stroke patient to arrive to the hospital because the ambulance has called the hospital and said they're coming. So I'm often there waiting before the patient is even there. Also, if the person gets worse, if you decide to drive them, you can't help and drive at the same time. And then the most important thing as someone who witnesses a stroke is to remember what time the stroke started. That way you can give that important information both to the ambulance people and to the providers at the emergency room. Oh, I did not enable, we have a stroke music video, but I don't think I enabled sound when I shared. Let me see if I can do that later. Well, let me see. Can you hear it? No? Okay. We'll move to stroke prevention then. So then what can you do to prevent a stroke? I have to say that our original work was not focused on stroke prevention. It was focused on stroke preparedness. And at the request of our community partners, we moved to stroke prevention. So I can vividly remember a CAB meeting where a gentleman made a comment that this is great, your little call 911 thing, but we want to prevent stroke. So can we do some of that too? And so I was pretty hesitant to move into the prevention space, but at with the support of Elder Bailey and the request of the CAB, we moved into stroke prevention. So what does that really mean? It really means hypertension. It really means blood pressure. So high blood pressure is the #1 cause of stroke. Other risk factors are diabetes or high sugar, tobacco, obesity, physical inactivity, poor diet, and stress, but really the #1 is high blood pressure. So these are the American Heart Association guidelines for what to do about blood pressure. So less than 120/80 is normal. Borderline is less than 129/80. At that point, you could consider talking to your doctor and changing your diet. After 130 to 180, it's considered high blood pressure, and you may need to start medicines at that point. So knowing what your blood pressure is, I think, is the first step, and then discussing that with your doctor and deciding which strategies, whether it's increasing your physical activity, changing your diet, or starting medications, is right for you.